Good afternoon, everybody, and welcome to this afternoon's session on intersectionality. I'm Kim Henderson. I'm the Director for Policy Evaluation and Learning at Our Watch, and I'm really pleased to be invited to facilitate the session today with the wonderful panellists to my right that we'll hear more about shortly. I'd just like to start by acknowledging the traditional owners of the land on which we meet today, the Wurundjeri people, and paying my respects to elders past, present and emerging. I've been asked to give a brief overview of the subject of intersectionality before we go into the panel discussion. It's not an easy task. It can be quite conceptual at times, but I think through the discussion and hearing from our panel members, we'll really get down to some practical applications that will hopefully be useful for you. So the phrase intersectionality was first coined by American civil rights and gender-based violence activist Kimberly Crenshaw in the late 1980s. And she used this term to highlight how multiple forms of exclusion and discrimination can impact upon people's experiences of marginalisation. And she also used the term to highlight the flip side of that, which is that multiple forms of privilege can interact with each other to accelerate a position of economic, political, social, cultural and informational power and privilege. So there are a lot of myths and misunderstandings and misapplications around intersectionality. In terms of the work of primary prevention, which is what Our Watch focuses on, intersectionality isn't about focusing on complex identities. So for us, for example, one's non-whiteness, gender, sexuality is not the problem, and the issue is not about problematizing intersecting identities. It's really about addressing and transforming social systems. For example, social welfare, access to justice, access to safety, education, health, etc. And making sure that those systems don't exclude groups and individuals. It's also not about the oppression Olympics, we could say. Audre Lorde is also another intersectional feminist theorist who strongly argues that there's no hierarchy of oppression. And quoting from her to give you an example, she says, "Within the lesbian community, I am black, and within the black community, I am a lesbian. Any attack against black people is a lesbian and gay issue because I and thousands of other black women are part of the lesbian community. Any attack against lesbians and gay people is a black issue because thousands of lesbians and gay men are black. There is no hierarchy of oppression." Intersectionality is also about considering bias. Conscious bias, but also unconscious bias, and how this influences our thinking. It's about thinking about the ways in which social structures intersect to compound experiences of disadvantage for particular cohorts of the population. However, it's often confused with diversity, and it's not a concept that substitutes for diversity, although we could say they're related. Applying an intersectional approach is different to promoting diversity because it considers more than one form of privilege and or discrimination at the same time. So Angela Davis, another intersectional theorist, argues it's not that we stop promoting diversity. Diversity is important. It makes our life, workplaces, schools, and communities in general richer. What needs to go hand in hand with promoting diversity, however, is the commitment to transform the social systems, societal attitudes, norms and behaviours that undermine or exclude people who are considered different. So it's about changing systems that are inherently biased and exclusionary, whether they're racist, sexist, ableist, homophobic, transphobic or ageist. So in terms of Our Watch's work on primary prevention, we need to look at the ways that women experience violence, and from there we address and identify the drivers of violence. So the research tells us that gender inequality is the main driver of violence against women, but we see that the real life experience of women in our communities are different from group to group. For example, Aboriginal women are 35 times more likely to be hospitalised by family violence than other women. So in our work, we recognise and identify the ways in which social systems, structures, attitudes, norms and behaviours intersect to compound experiences of disadvantage and of violence. So that's a very brief overview of a topic that I'm sure we could spend days or weeks on, but I don't want to take up more time than that, and I'm very pleased to introduce the panellists. We have Roshan Bandri, the Executive Manager from InTouch, Star Lady, to my right, Youth Project Officer, and we have Suchita Chari at the end here, who's a survivor advocate. And I'm going to call on them each to respond to a question, and following that we'll open the floor for discussion. Unfortunately, we did have another panellist, one of my colleagues, Carla McGrady, who was going to speak to how we've applied an intersectional strategy at Our Watch, but she's not well today. But that just gives other panellists more time to speak. So I'll start off with Star Lady. Hospitals have not always been safe spaces for LGBTIQ+ people. What are some of the key factors in providing more sensitive care for trans, gender diverse and non-binary people who might be experiencing family violence?
Cool. Thank you for having me. My name's Star Lady. I identify as trans or gender diverse, and my pronouns are she, her, and hers. I think when talking about broadly, we've got family violence and we've got hospitals. When we're talking broadly about family violence, we have come from a history of looking at family violence as this lens of men's violence against women. And that automatically excludes a large percentage of our population who might identify as lesbian, gay, bisexual, trans, intersex, or queer. In terms of the T, trans and gender diverse, the family violence sector and the sexual assault sector have both emerged out of the feminist movement, which has really created, a safe space for women. But currently, one of the issues that I see is, as historically as part of the feminist movement, there has been a small part of that community that has excluded trans and gender diverse people in particular. And I would say that trans rights and the feminist movement are not mutually exclusive. That actually, overcoming, misogyny and the patriarchy will take all of us coming together and working together to be able to overcome that. So feminism and trans rights are things that can work really powerfully together. But because of that narrative where trans and gender diverse people, in particular trans feminine people, have been excluded from women's services, trans and gender diverse people may feel apprehensive and nervous, or it's generally known that trans and gender diverse people often self-exclude from accessing care, and healthcare in particular, because of past experiences of discrimination that they have directly experienced, or that their friends or family have. And I also think we need to look at it in the context of the era that we're in. And so we've also got to be thinking about, we've just come in Australia, we have a massive movement towards the right. Anti-LGBTI, anti-equality in lots of different ways, around race, around religion, around sexuality, and around gender identity. And when we have that, it empowers people in our society who don't have inclusive views to exclude people. And so there will broadly between many communities who may have increased fear or apprehension around accessing particular services. And when communities are more vulnerable, we've got to be thinking about how do we reach out to those communities to actively tell them that our services are inclusive. And so I would say from a trans and gender diverse perspective, unless you're actively promoting your service and you as an individual practitioner are a safe and inclusive service to access, then people may self-exclude. And so you may not even see them. They mightn't even come to your service. And so I think that's one of the larger barriers for trans and gender diverse people accessing care. And also when we've come from this history of that family violence is men's violence against women, all of the systems that we have created exclude trans and gender diverse people. So that might be our intake. It's also the training that we've received. It's all our advertising materials. It's all our websites. And when all those things that we have, those systems to be able to support people, exclude people, even when they access that care, they may feel that that level of care is poor. And then we as workers might have incredibly inclusive views, but sometimes we mightn't be able to see and understand the systemic discrimination that is happening and why clients may be getting upset or feeling marginalised. I think about it in terms of hospitals. I know I'm from the Zobel Gender Collective. It's a trans and gender diverse advocacy group. And I know that our community in particular has highlighted that hospitals are some of the most unsafe spaces for trans and gender diverse people to access. We have not done broadly done the LGBTIQ cultural competency training or adapted our policies and procedures to make those safe. If we look at even the Melbourne-based hospitals, they are only just beginning to form their own staff LGBTIQ working groups. If you think of even just accessing a hospital, when our forms are saying, are you a man or are you a woman, and that's it? Are you even creating the opportunities for people to disclose and share that information to you? And then even once they do disclose that information, if you actively ask, have you got anywhere to record that? How are you having conversations with your clients then to manage their confidentiality and disclosure? Quite often when you're in a hospital ward, the surgeons and the doctors may be asking very invasive questions around trans and gender diverse people's bodies without being aware that trans and gender diverse people's bodies have a history of being objectified, sexualized, and subject to abuse. So when the doctors and surgeons are going, have you had the surgery? Or have you had breast augmentation? Or have you had breast reduction, or top surgery? When they're asking those questions, they may not realise how that is a very sensitive subject for trans and gender diverse people. And if you say that loudly in a room with just a curtain dividing the beds, then you could potentially be outing your client, your patient, to the person in the next bed. And when trans and gender diverse people are subject to incredibly high rates of verbal or physical abuse, you may be putting your client, your patient, at incredible risk of physical or verbal abuse. Are we considering in hospitals, do you have any safety concerns while you're here? Would you like us to consider your room assignment? Things like that is managing people's safety. I don't think we're doing, not even the most basic level of care. And I think it's because sometimes people feel like, if I ask around people's gender identity, their sexuality, or their intersex status, that they are being invasive, that's people's personal things. And I would say that at times, it's just important to create opportunities for people to disclose if they would like to, if they feel that it might be relevant to their care, because it very well could be. Like if somebody has come in after experiencing physical assault, say, well, actually that physical assault could have been around their gender or their sexuality. Unless we're inviting them to share that information, then we may not get the information that is actually vital to their care. I also think in terms of in particular around family violence, when we've only been offered that training, I guess where the training is about men's violence against women, we don't know that the family violence against trans and gender diverse people can look incredibly different. Power and control looks different in trans and gender diverse people's relationships. We've got to be thinking about the stigma in terms of relationships, in terms of trans and gender diverse people and their relationships. How many trans and gender diverse people do you see in Hollywood or in our popular press and their relationships? We don't see healthy examples of that, and there is still an incredible amount of stigma in our society. For some people, maybe their dates will never actually date them in public because of that stigma that exists in society. And so, you know, all of your safety factors and how you protect yourself and the types of violence you might, or control you might be experiencing, is incredibly different.
Okay. Thank you very
You're
much,
welcome.
Star Lady. A lot to think about and to discuss in what you've shared there. I'd like to hand over now to Rashan and ask you, Rashan, why is it so important to talk about intersectionality when working with women from multicultural communities, and what practical hints do you have to help us enable this discussion?
Thank you, Kim. So Kim has already given us the definition of intersectionality and what intersectionality looks like in primary prevention. And our watch has a lot of resources and a practice guideline in terms of what intersectionality could look like in primary prevention space. So what I'm going to talk a little bit about what intersectionality looks like in early intervention and intervention, because I assume that a lot of us are frontline workers. So, you know, just to reiterate the definition of intersectionality, it is a lens. It's actually a lens or a framework that recognizes multiple identities and experience of individuals which could interact with each other, and when combined with systemic barriers and structures, creates further disadvantage. So when we're talking about family violence, women, in majority of the case, could be one identity, and the experience of family violence could just be one experience. But there are so many different identities and the experience that individual could have. For example, in the context of multicultural community, a woman who comes to Australia on a spousal visa, it might have additional barriers and challenges in terms of that systemic barrier rather than someone who comes here as a skilled migrant. Yeah? And some of the barriers in terms of the systemic barriers for that woman on temporary migration visa could be, the systems could be the immigration department. That's a system. So because of her identity as a temporary migrant and her experience of family violence, she might not be eligible for permanent residency. Housing is another system, so she might not be eligible for public housing because of her identity. The other system could be Centrelink. Because of her identity, she might not be eligible for Centrelink public benefits or the settlement support. So these are the systems that she might not have equal rights, or she might be further disadvantaged. So why do we talk about intersectionality? So we have to talk about intersectionality because it recognizes and it looks at an individual in its holistic sense. So after you become aware of the multiple identities and experience and multiple barriers, you get to know her worldview, and it also impacts on the client's ability in accessing, trusting, and engaging with service providers. So hopefully that's clear enough, because the concept of intersectionality, even though it has been around from the 80s, it's really difficult to translate into what it looks like in practical sense. And Family Safety Victoria and other government departments are trying to come up with a training that's going to be rolled out in terms of what that could look like in intervention. But I also want to talk a little bit about some of the practical tips for applying intersectionality in your day-to-day practice. As Kim mentioned, intersectionality in primary prevention space could be for that systemic advocacy, right? Dealing with the isms. It could still look like that in the intervention space, but what we can do is really adopt some of the best practice strategies in our everyday life. And in the context of multicultural communities, I would say the mantra is one size fits all, denounce that theory because it does not apply to anyone. I'm from Nepal and I'm a migrant myself, so even if I talk about my particular culture, there are so many diversities within that. So, the frontline workers usually tend to generalize, based on a typical culture or ethnicity, and that's very harmful. So the intersectionality approach really calls for the individualized and the strength-based approach. It also recognizes the power imbalance, and that's where Kim was mentioning about being aware of your biases, conscious or unconscious bias, but also looking into your own privilege. And the power imbalance between your clients and yourself. It starts with the awareness of the individual's individual, systemic, and communal barriers, because there could be layers and layers of those there. So I guess I'll just, I think the outcome for intersectionality is inclusion and equity, as opposed to diversity, which the outcome could be inclusion only. So intersectionality is a little bit ahead of the diversity framework. It does not substitute, but it calls for inclusive practice as well as equitable practices.
Thank you very much. I'd like to move now to Suchitra and ask you, you've previously spoken about your experience of trauma and recovery from sustained family violence as a new migrant. You are now survivor advocate and mental health social worker. Can you comment on the complexities of trauma and recovery for intersectional women?
Yeah, thank you for this opportunity. And earlier, I think you just started this conversation with thanking the traditional owners of this land. But I always take this opportunity to thank every woman who has suffered and who has made the policies and programs in this country where it is today, because I am a beneficiary of every single woman's information and experiences that has informed what the society is today. And I don't say that lightly, because I travel between two countries and my identity is across two countries and two ethnicities. And so what I have gained here is not lost upon me. And what I speak here also is informed by not just my lived experience. There is a very big element of it. I've had 28 years of trauma, and I'm a 53-year-old woman, so I've had more trauma than lived experiences of healthy, normal life. So to ask a simple question like, what does recovery mean for me, and where I am at? I just want to start back from the conversation that I saw, actually a screen that I saw earlier when I just walked into this room. I think Kelsey was talking about the questionnaire and tools that have been developed to help sensitively ask somebody what their experience is and whether they're experiencing safety now. And the very first question that I saw there was, are you feeling threatened or intimidated right now? And I was thinking, as a migrant, 31 years ago, when I was being beaten up black and blue, if somebody had asked me that question, absolutely I would have said yes. But the threat was not just directed at me. The threat was directed at my brothers, that they were going to be murdered overseas. The threat was directed at my parents, that they were going to be somehow persecuted. So if I had openly answered and said yes, that I am at risk, what could the worker have done? I don't think we have progressed very far from that, because we still take a very narrow view of what the safety is. That's the first question. The response to me that stuck out. The second aspect of it that stuck out to me was my own immigrant woman's identity. So before I entered this country, I went through about 4 months of visa processing requirements. And I still recall the medical tests that I had to go through. So I had given blood tests, and I was having some respiratory disease, so I was asked to go for a second blood test. So we were screened, and we were declared that I was fit and healthy and well enough to come here. The same tests were given to my ex-husband as well, and he was screened for physical wellness. There is not a single questionnaire that screens a migrant even today about his attitude to women. And I think if you're brandishing in every TV, every commercial, every a radio commercial that comes on respect, and what respect looks like and what lack of respect looks like. And if that's the message that Australian government wants to project to the community, that we take women's health and safety seriously, I can't understand why they can't screen it and convey the message at the port of embarkation that this is the culture and norm in Australia. Do you fit within that? Yeah, so we don't do that. So the complex experiences of trauma and recovery is constantly a juggle between what the government is trying to do and what has been failed to me, and the vision that I see for the Australian woman. And what I mean by that is the dominant Australian woman, who is, by virtue of her ethnicity or by virtue of a citizenship status, is very privileged. And so I come from that experience saying there is still a lot more to do where we are at. And the next thing that I also look at is I'm a mental health social worker. I trained very hard through intense depths of post-traumatic stress disorder and major depressive disorder and borderline personality disorder. Every disorder label I have carried. So today, to be asked to come and speak in the forum of intersectionality, the first impression that I formed is that is yet another box into which I need to be fitted. And as a mental health social worker, I can clearly understand what intersectionality is and what we are aiming to achieve. But when I put on the hat of a survivor advocate, I don't want any more labels. If we got it right, if we believed in person-centered care, if we believed in individualized care plan, we won't need these multiple boxes into which we need to fit people. But that's not to say that their experience of different levels of disempowerment and discrimination is going to go away, but you're going to treat every individual with the same respect and same dignity that they deserve and the same level of access to services that they deserve. And I say this also in the context of my attempts to contribute and inform the Royal Commission on Child Sexual Abuse towards Children in an institutionalized context. So I'm a survivor of child sexual abuse and domestic violence. So I felt immensely proud that as a migrant, I'll be able to contribute and inform the Royal Commission on Child Sexual Abuse. So I rang them, I wrote a petition, and the information was, because all your incidences happened in another country, it does not fall within our boundaries of investigation or inquiry. So thank you for telling us. We will invite you for a half-an-hour cup of tea, but your experiences will be minimized because it happened outside the borders. Practically, I absolutely get it. You need to actually draw the boundaries somewhere, and yet you're telling me that you're allowing me to be inclusive into the boundaries of this country, but my experiences have to stay somewhere else. I can't divide myself to leave my experiences that happened there and project an image that you want me to be projecting here. I am a composite, complex package. So I think we somehow lose that in our inclusiveness. And I don't know whether it happens at multiple levels for multiple ethnicity, but this has been my experience in relating to dealing with my trauma and my mental illness and arriving where I have here today. So while I'm absolutely grateful for this dialogue and this conversation on, sorry, I've just lost that word. Intersectionality.
It is not easy to remember.
So it's not lost upon me that even that has got such a multiple layers that you can cut out of it and analyze somebody's experiences out of that. And coming directly to my experiences, I think even though we are sitting here in 2018 and we've had that many levels of conversations at schools and tertiary institutions and professional institutions, I experienced firsthand, and I was absolutely stumped when it happened to me. On the Age newspaper, I was featured in an article not very long ago, and I had disclosed a little bit of information about me, and it was passed on to a journalist. And at nowhere had I said, at no time in the conversation, or none of my, I don't have a social media presence, nowhere have I disclosed that I am somebody who arrived into Australia as an arranged marriage migrant. So this journalist happened to see my photograph and assumed that I must be somebody who had an arranged marriage by virtue of my ethnicity. So I asked Age to recall that article that they had actually written. And for me, it was a point that no matter how much I might speak, no matter how much I might be projecting the professional woman that I am, what people see me is my ethnicity first and foremost, and the preconceived notion of what my history might be. So the call here for every one of us is to actually look beyond the person, not just what they are projecting. Did that cover what you wanted to talk about? And then some.
Thank you very much. Thank you for sharing your experience.
I would like to ask a question to Star Lady about, I think we have a lot of training provided to us as health professionals about culturally safe practice, but I'm just wondering if you can tell me how I can get some training about, I guess, gender safe practice.
There's a number of different organisations who provide that. Transgender Victoria, my organisation, the Zobel Gender Collective, and there's some youth-based organisations like Minus 18 and Y Gender as well.
Is that it, or one question for each panellist?
Yeah.
No?
Yeah.
Sorry, I think we have to bring. I think we've got to bring the panel to a close. Really sorry to rush through this, but I think we've heard some really invaluable thoughts and experiences, and a few common themes that I'd like to just wrap up with and leave you to think about. So I think questions we can ask as we walk out of the room in our work that have come through in all three panellists' conversations. How are we framing theories and practical approaches for inclusive and equitable outcomes? I think that's something that you all spoke to. And what the impacts and the consequences are when we don't do that these are deep and harmful. How framing drives systems at the overarching level, but also practical approaches. And I think you all spoke about what some of the gaps are at both the systemic and the practical levels, but also gave some really concrete suggestions on how we can make these changes, from the very practical, moving away from male, female boxes on our forms, to the more systemic, where we acknowledge multiple and complex identities. And I think a common theme from all three panellists was to really urge us to move away from labels to people-centred individual care, as you mentioned, and I think you put it really nicely to close with in saying that you are, and I think many people are, composite and complex packages. Thank you very much, everybody.